We did not know anything about this study when we started the similar study instead, which is called Temendo, comparing transanal endoscopic microsurgery with ESD for the same indication. And there, analyzing only prospective study, as there is no direct comparison between techniques and not even randomized trial even between techniques, what we did is we discovered, as you see, that the size of lesions here is instead relatively similar. There is no statistical significance among the two groups. And the reason why I cannot report fully the results of this study here, retrospectively, is because I am still awaiting from one Japanese centers of the many that accepted to send directly the Excel sheet of the ESD cases limited to the rectum, which is the other bias of the Dutch trial that compared also cases taken out from the colon. We limited it only in the rectum. The reason why I cannot give you final results is that I'm still waiting for some data regarding recurrence. But as you see here, despite not significant, there is a difference in R0 resection, which is 86% in TM and 70% down here in the ESD group, as well as procedural complications that unexpectedly, I have to say, having experience of both, are more or less the same in the two groups. So let's go back to the beginning of the presentation. What should we do when we are in front of this lesion now? Well, what I try to summarize here is what appears to me clear from the literature and from the experience gained in these 20 years since I was trained in Tübingen. And is that, first of all, we have to split lesions located in the colon and lesions located in the rectum. Those located in the colon should be all classified by Kudo, and all cases 1, 2, and 3, according to Kudo or biopsy as benign, should go EMR if smaller than 2 centimeters, should possibly go ESD if you're really skilled, or piecemeal EMR if they are larger than 2 centimeters. For those 4 and 5, if possible, you should do an endoscopic ultrasound by mini probe, and depending on the evidence of infiltration of the submucosa, you should either stay with the options offered by flexible endoscopy or move to radical surgery directly without running the risk of the complications that are increased in all series reported when you deal with cancers and you try to resect them endoscopically. Well, for the rectum, you cannot deny that there is an option offered today by TEM, that is offered since almost 30 years, that is TEM, that it was very difficult to perform till 2 or 3 years ago because it needed much skills, it needed a dedicated instrumentarium which was very expensive, it needed a long learning curve, but today, thanks also to Karl Storz that offers a renovated set for transanal endoscopic microsurgery called TEO, can be easily implemented in many centers, and therefore, for all lesions suspected as benign, larger than 2 centimeters in the rectum, I would consider the option of transanal surgery. To me, it is more interesting to discuss today with you what to do not when you first see the patient and you have to decide which strategy to do, but when the patient is referred to you after the lesion has been resected. And this is what also the previous speaker tried to underline. And this is, to me, what creates more concern in my daily activity. Being a tertiary university center, we receive most of the patients already treated by other centers, and it's always very difficult to decide what to do. So I want to make it very clear now that EMR and ESD performed macroscopically till an R0 stage, and that discovered low-grade or high-grade dysplasia, if had, sorry for the Italian, clear margins or invaluable margins, do not represent an indication to any surgery. These patients have to be simply followed up as strict as you would like but simply followed up. And if the lesion is benign, also if the margins were infiltrated by the disease, they do not represent an indication to surgery. There is no indication for surgery after an infiltrated margin of any dysplastic lesions. You can still go in and resect it. You can still follow up the patient and resect it at 3 months when the recurrence is evident. Not surgery for these patients. But what about if we unfortunately happen to receive a patient that had an EMR or EST for an adenocarcinoma, an unknown adenocarcinoma revealed at final pathology? Well, if the margins are free and the lesion is as high as SM1 for depth of invasion, follow up. There is no indication for surgery. No indication for surgery. If it's not simply an SM1, then you should discuss with the patient what to do, and I will offer some options now. But similarly goes for patients that do not have margins that can be evaluated. Again, if there is no infiltration of the cancer in the submucosal layer, please leave the patient to the follow-up. Don't go for radical surgery. There is no indication at all. Whether if there is infiltration of the margins, then you should go for radical surgery if the cancer is evidently in the submucosal layer, because you cannot assess, in this case, the risk of recurrence, which is relatively high, and therefore you're obliged to take the patient to radical surgery. Few words about transanal endoscopic microsurgery. This is Gerard Buers that unfortunately left us about 2 years ago, still very young. When he was 32, he invented the instrumentarium that you see here in an age in which laparoscopy was still far away to come, and that allows today to resect similar cases. Now, how many of you would do flexible endoscopy resection, whichever means you would prefer to use, I mean, EMR or ESD to such a lesion? Well, if I see such a lesion in the rectum, I never try to resect it by flexible endoscopy. And the reason is that such a surgery does not have any mortality, does not have serious complications. It can be done with a 24-hour inpatient hospital stay, and it takes general anesthesia, you're right, but it lasts not more than 30 to 40 minutes, and those of you who came to visit our center know that I'm not kidding. It can be argued if this is overtreatment or not. Well, I can say now that this was an SM2 lesion, and by doing this, for sure I offered the patient a higher incidence of free margins on the specimen resected. This is what we wanted to have. And then afterwards, up to the patient to decide whether to run the risk of keeping a 6% of lymph node metastasis or not, or prefer to go for radical surgery. I think it's clear that the kind of dissection is completely different from the one that is offered today by flexible endoscopy. And I think that it's clear that once the specimen is retrieved, the wound that you leave in the rectum also allows further technique I'm going to explain now in more details very shortly. Why transanal endoscopic microsurgery is a question that I would like not to answer any longer. There is no role anymore for conventional transanal local excision. This is surgery of 30 years ago that should be abandoned. Also for the lower lesions, the precision that you offer by TEM is highly increased. And you see them represented in these graphics by recurrence-free survival and local recurrence-free survival, as well as why TEM. TEM also because in those cases, and from the beginning of the year, I already had, unfortunately, the chance to discover in 5 patients a cancer which was not known before surgery. In those patients, I still offer the chance of an immediate salvage surgery with similar results as if the patient would have been operated radically from the beginning, which is not the case if you do it by local excision simply. Now, it can be argued, and I have to be honest, I'm starting to rethink about this opportunity. It can be argued that TEM can also be used for different indications. Means, first of all, it is not the case always to perform a full thickness resection. Well, I am very much in favor of this technique now, and probably will reconsider this in the next cases. This was described by Dr. Borley from the UK, that stated that he is discharging all the patients 23 hours after the procedure using TEM only for submucosal dissection, basically, lifting the lesion and resecting it like we magnificently observed in the previous presentation, but in a surgical way, controlling the bleeding, suturing the defect, and obtaining a higher percentage of free margins, of course, as described before. What you see here, the strange thing, is that we all believe that in Japan, all these lesions are treated endoscopically. Well, what you have seen is a video by my friend Eiji Kaneira, who works at the National Cancer Institute in Tokyo and uses routinely TEM for endoscopic submucosal dissection. So probably even there they have some doubts of which is the best way to do it. I would like to, 2 minutes more, describe what are the potentials of TEM and the future of TEM now. One thing is that TEM can be associated to complementary techniques, means, for instance, sampling of sentinel lymph nodes. This can be done laparoscopically for the upper rectum, but can also be done through the same wound, thanks to indocyanine fluorescence, while doing TEM in a suspected lesion for cancer, and this is something that cannot be done by flexible endoscopy, for instance. So we are just starting a study now for Karl Storz. We will inject indocyanine in the four quadrants before resecting the specimen, and after that, thanks to this technology, we would look for the lymph nodes and sample it and see if they have metastasis or not, and in that case, we will proceed for radical surgery. The second thing that TEM can do is the treatment of downstaged rectal lesions by preoperative treatment with radio and chemotherapy. We do have a protocol running now for T2 lesions that are downstage or at least not progressing after neoadjuvant radiotherapy. In those cases, we do perform TEM, and up to now, we did not experience any recurrence yet. So I think we can say that those patients are very likely to respond like SM1 cancers if treated in this combined way. It is not only our idea. Professor Lezzocca in Rome is doing this since more than 10 years, and he already reported the 10 years results, but there are now many centers in the world who do have this indication for TEM. It is always difficult to say to a patient that has a resection, either by flexible endoscopy or by TEM, of an SM2 cancer that he needs major radical surgery, possibly with a stoma, permanent or not, because he has a 6% rate of lymph node metastasis. It's difficult to accept. It means that 94% of the cases, this is overtreatment. So we are trying also to understand if there is any mean to understand after surgery if you can assess the positive lymph nodes or not. And I have to report, unfortunately, that we had a series of patients who underwent PET after surgery, and that were addressed to radical surgery afterwards, and unfortunately, all those who had lymph node metastasis were not detected preoperatively by PET. So I think this technology, unfortunately, today does not help us in this. Now, why are we talking about these superficial lesions? Today, we have learned a lot of techniques trying to help us to detect as many difficult lesions to see as possible, because there is a clear trend towards early rectal and colonic lesions thanks to the screening programs. But are we sure that the technology we are using today will be the technology in the next 5 years? I'm very much convinced not. And what I'm showing to you is a project that we developed together with Scuola Superiore Sant'Anna in Pisa of a robotic capsule that will help in addressing all the issues, the technical issues that were discussed today. This is a camera. It's a wired camera, but we also have the wireless camera that embeds 2 magnets inside, and that is moved thanks to a permanent magnet connected to a robot outside the patient. And the robot allows you to move the capsule by establishing a magnetic field, and this makes the capsule travel along the colon if inserted transanally. And this is the setting that we created in experimental model. As you see, this has been tried also in vivo many times, but I think that this gives you a demonstration of what it is, the technology today. Those pink colors are molded polyps, of course. And the interesting thing is that we tried this in this experimental setting, and expert endoscopists like I am with standard colonoscopy do not perform as well as untrained students with this novel technology. So the potentials of these applied to screening is in my opinion, fantastic. And despite I do not think that there is a future for biopsy, we already prepared a version of capsule that embeds a biopsy forceps as well as a snare, so that you see that you can do all the operative things through the same technology as well. Maybe not as complex as before, but easy polyps for sure, yes. So what is the future? Well, if I would have the same results by flexible endoscopy and general surgery for a number of reasons that I'm not going to list here, of course I would prefer flexible endoscopy. But I think today the way I do flexible endoscopy while removing these polyps is still primitive, very barbarian. I think we have to implement new technologies to do this in a more surgical way, and this is why we participated to the Arachnes project, which is a project to develop novel robotic tools that I think should be applied to endoluminal treatment, as well as the stiff flop that just started in Torino, led by the King's College of London, that would like to create a robot based on a different principle, that is the arm of the octopus, very flexible, not very rigid, but then becoming stiff when it needs. And through these technology, I think we would like to create new endoluminal tools, like what we call the Mickey Mouse, that I'm sure will help us in future to solve the question how to treat these early rectal and colorectal lesions. And I thank you for the attention.